Reflections of a Point-of-Care Coordinator, Challenges to Preparedness. This is Peggy Mann, Point-of-Care, Lab and Facility Coordinator for Clinic Administration at the University of Texas Medical Branch. Our university campus is on Galveston Island, with patient care services extending through the southeast region of Texas. Our healthcare system pretty much sits right on the Texas Gulf Coast. My professional background includes 30 years of clinical laboratory work, with about 15 of those concentrated in point-of-care testing. The last 6 years I've worked in clinic administration, so through the years I've worked through the Department of Pathology and done point-of-care testing oversight on campus, and through clinic administration, point-of-care oversight off campus. Before going forward, I do want to say thank you to Dr. Jerry Cost at UC Davis for inviting me to participate in their point-of-care YouTube series. This talk gives me the opportunity to reflect on my experiences related to Hurricane Ike hitting Galveston Island. This happened in September 2008, 8 months ago. I'll be referring to my experiences during the initial post-Ike recovery phase, but I will not be discussing rescue operations. The objectives for this talk include discuss types of point-of-care used during disaster recovery, list benefits of point-of-care, i.e. when it worked, environmental changes occurring during disasters, list drawbacks of point-of-care testing, particularly didn't work, suggest applicability to other disaster settings, and provide recommendations and suggestions potentially helpful to other point-of-care coordinators and laboratory facilities. Here's a slide, different settings at UTMB. These were taken pre-Ike. Established in 1891 as the University of Texas Medical Department, UTMB has grown from one building, 23 students, and 13 faculty members to a modern health science center with 70 major buildings. Pre-Ike we had more than 2,500 students, and we had more than 1,000 faculty. Our campus is 84 acres, which includes 4 schools, 3 institutes for advanced studies, and a network of hospitals and clinics that provide a full range of primary care and specialized medical care. UTMB is a component of the University of Texas system. For perspective regarding how extensive the UTMB outreach is, the Regional Maternal Child Health Program has an outpatient clinic as far away as 180 miles from campus. As far as the UTMB point-of-care program, it was established about 15 years ago. Pre-Ike, the clinical laboratory position involved a point-of-care director and 1 FTE point-of-care coordinator. My full-time position, paid through the clinic administration, combines point-of-care, reference lab oversight, and numerous patient safety-related institutional committee duties. Now, post-Ike, the FTE from the laboratory also shares duties with the laboratory and with students, so at this time she is not a full-time point-of-care coordinator. I am still full-time point-of-care coordinator. However, I doubled the number of clinics. So both of us are pretty busy running around trying to maintain the university point-of-care. The next slide shows a shot of Ike coming on in across Texas. If you look carefully at the picture, on the left there's a darker green crescent, and that would be the Gulf Coast evacuating patients. On Tuesday, September 9th and Wednesday, September 10th, the state of Texas Operations Center pre-positioned ambulances in San Antonio and Austin, Texas. So when the final decision to evacuate the hospital was made by UTMB leaders, the resources were en route to Galveston almost immediately. The city of Galveston ordered the evacuation of the island Thursday, September 11th. The residents of Galveston pretty much took it seriously and got out of Dodge. The hospital released all of its non-essential hospital personnel and including all students. Throughout September 11th, the patients were discharged or relocated by quite a variety of transportation. We have ambulances, buses, other ground transportation. By air, there were helicopters and fixed-wing aircraft carrying patients out. This slide shows at the upper left, this was during the accumulation of the floodwaters coming onto campus. The other three pictures are post-Ike. The highest surge level in Galveston reportedly was between 9 and 11 feet. Issues for UTMB recovery included salt water. Not only was a lot of the vegetation on the island killed, one of the things that happened to the campus was the steam pipes in the campus facilities failed due to the salt water. Lost services due to being located on the first floor of the campus buildings included the loss of the pharmacies, blood bank, kitchen, patient meal preparation areas, the cafeteria, all of the retail facilities, the entire radiation oncology department. Quite a few of the clinics were on first floors of buildings, and they all had to move off campus. There were several other buildings that have not been restored to usefulness at this time. This slide shows a couple of pictures to indicate, number one, the extensive flooding, and the top picture, pretty much devastation of that strip with the water coming in and the windstorm. There was one house left on that stretch. I did hear from several coordinators in Ohio that also suffered extensive power outages due to Ike. The official word on the hurricane duration was about 10 days. The next slide shows a pile of debris. It was not pushed there by a bunch of bulldozers. That is debris that came in with the water. A lot of the dikes and the little piers that held restaurants or souvenir shops were completely destroyed, and all of that debris came up on the island. You are seeing Seawall Boulevard, which is totally blocked off by this particular pile of debris. The next slide shows some pictures I've labeled UTMB recovery. Daily things get better. It seems like it's taken quite a while, but every day seems to be a little bit better. Less than a week post-Ike, the off-site clinics were seeing patients. Our limiting factor was when the electricity came on to that geographical area. If the electricity was on, we had clinic. 30 days after the storm, the first patient was admitted back into the hospital, and by December 19th, UTMB staff had delivered 1,000 babies. As Mike Magna, the UTMB Institutional Preparedness Officer, stated in the April 2009 issue of the Environment of Care News, "It's nice to know that life goes on." Point of care utility during and post-disaster. Point of care can be a flexible option. It adds to clinical laboratory services in a variety of models, and during and post-disaster is a model quite useful. I did mention in the opening that Dr. Cost, in one of his lectures, talks about rescue efforts, and he references Thailand, tsunami, and New Orleans Katrina efforts in the point of care strategy series. Utilizing point of care testing at UTMB post-disaster was indeed made easier since we have such a well-established program. I mean, for 15 years, we haven't had to tweak the program too much. So the point of care was then immediately available for those practitioners who had to come off the island, off campus, to practice in the off-site clinics. Quite a few of them had never practiced off campus before, and there is a big difference between having a clinic on campus and off campus as far as the availability of services. It was really a benefit to have the same program on campus and off campus, because that was the flexibility part of providing almost seamlessly for the patient care activities that we had to move off campus. Point-of-care testing itself is a flexible strategy because it provides lab testing outside of the lab environment, and so folks are already used to leading and managing and overseeing activities provided by non-laboratorians. This slide uses as an example of how one can use an alternative non-connected meter to continue to provide the service to patients and the service to providers while within the parameters of an existing established point-of-care program. What we had to do to go off campus for providers is get additional meters, and we could not use meters that were connected, which is what the operators were used to. However, with the help of our local industry rep, I was able to get meters that use the same reagents as the connected meters used on campus. That cut down the learning curve drastically, and that's part of the flexibility that I think point of care offers, especially with industry being very user-friendly, I believe, in the point of care arena because they're used to working outside of the lab environment with different disciplines, and they understood the nursing concern of having these tests available, but we simply could not use the exact same meter that was used on campus. The list on the left of this slide shows the types of point of care used pre and post disaster. Now, several factors contributed to point of care testing volume increase, although one must keep in mind that there was a decrease in the number of patients initially that we saw in healthcare off the island and the community clinics because folks who had evacuated were learning there was either nothing to go back to or the damage was so severe they could not literally move back to the island. They were relocating in different areas as far away as Houston. So we did not get back initially the patients that we were anticipating. However, over time, we did build up the patient base again. Now, in our off-sites, we were seeing more patients than we were used to simply because we were also seeing patients that normally would have been seen on campus. The campus clinics were used to not doing as much point-of-care testing, and they were used to having the clinical laboratory service right there. We are used to not having the clinical laboratory service right there because we're all off-site in the clinics where I oversee, and the clinic area where I work, we already have a few reference lab accounts. However, our clinical laboratory was closed for at least a month, and so that increased the volume of testing that we were sending to other reference labs, but it didn't impact the number of tests that we did as point-of-care tests because we were providing the point-of-care testing for additional physicians and nurse practitioners. We were also providing services for other doctors' offices, non-UTMB, that had gotten damaged and that were scrambling to restore their services. So we were doing additional point-of-care testing across the board for other facilities, for our own facilities, and because our clinical laboratory was closed, we were doing more urine dipsticks, more rapid streps as a result of the lab not being able to function. On the next slide, we'll go into some benefits of using point-of-care testing. With the UTMB lab closed for a month post-Ike, the immediate results the providers could get from using point-of-care was a relief to them because they were used to having that laboratory a couple of floors away. Especially since we were wall-to-wall with providers working in every available space, we really had to get patients through the laboratory and through the clinic environment off-site as quickly as possible. The number of exam rooms, for example, in each existing off-site clinic had to be divvied up to accommodate the additional physicians and nurses coming off campus to see their patients. It's always a goal of moving patients as rapidly as possible through the clinic environment for their patient satisfaction. But it took on even more emphasis because we did not want to have to extend the hours of the off-site clinics. We didn't want to be open until midnight to accommodate the number of patients we had to see because of the lack of space. Some benefits of having point of care available on and off campus are included in these slides. As far as supplies and reagents, for example, the benefit of using point of care and having the same program across the board is that we were able to get reagents and supplies very rapidly. For example, the materials management department on campus not only had trouble getting the supplies initially because it simply was difficult for traffic to get on the island initially because they had to first do rescue and then they had to do basic infrastructure support and rebuilding, and everything else had to wait. So there simply wasn't the delivery of supplies initially to count on as far as getting them from materials management, plus the building was damaged, plus there was a lack of distribution availability. So the fact that we already had existing accounts for the point of care areas off campus came in very handy because we already had commercial distributors set up that we could tap into. And then from there, we could distribute those reagents and supplies throughout the system. And then when our clinics moved back to campus, we could also be available to order supplies off campus and transport them to campus if they were not available by then. The next slide shows a screenshot of our point of care website, which fortunately the university has a wonderful backup system so that I had evacuated and I could keep track of what was going on at the university because of the web page. And within the few days that we had to start back work in off-site clinics and people were coming off the island, point of care operators were being relocated, and I had to determine did they have competency, what testing were they doing on campus. If I ran into folks who were reassigned and had not been trained to do whatever testing they had to do off campus, I immediately had access to the point of care website because of the wonderful job that the group did in keeping the sites viable. And this is a screenshot that would show the formulary, so the testing that was available, and also the ordering of supplies. The information's on this particular page. But the competency, we have online competency through our web page, and that was really a good asset. Now the environments that get impacted, that was a challenge for us. The number one was unstable temperatures, and that is in the instrumentation, of course, that's used in point of care. Dr. Koss points out that the devices are not all that robust. Now, to use them off-site was not a problem for us because we had temperature regulation in our clinic environments, or we wouldn't have been seeing patients there. However, it would be more of an impact if you were trying to use them during a recovery that was on the island, or you were using it for the actual disaster relief. The unstable temperatures impacted us because we didn't know what was going to happen to some of the equipment just lying around when it was 100 degrees for long periods of time. The reagent storage was more of an impact, of course, because we had to throw away just thousands of dollars of reagents and products that had been on campus and for which we had no temperature control. Now, the unstable environments also have to include mold, the residue. The floor was just a mess in all of the areas, obviously, that got flooded, and it's very difficult to describe, but with water coming into the facilities, things get knocked over, filing cabinets, things get messed up in drawers, and then you don't know what leaks out. Depending on where the storage was, everything was just pretty much unusable under the water line for sure, but even above the water line, you weren't quite sure because you didn't know about the mold and what other agents was growing because of the environment. Just in case you're curious, on the bottom picture there's a big white plastic tube that's coming across the ceiling, and that was everywhere you went on campus. The fresh, chilled air would have to be brought into the building to circulate because the air conditioners would not be running full steam ahead. We would have electricity enough for lights, but there were quite a few things that were compromised in the environments. On the next page, I do detail some things related to employee. Human resource as an environment was very much impacted by stress on two fronts, both work and home. And it was a vicious cycle because folks who actually could come to work, they had a job to come to, they might be working in a different position, they might be working in a different location. Some of these folks had pretty much lived and worked on the island their whole careers, and their job might be off the island during this recovery period. They weren't used to commuting. They had all kinds of family concerns related to having to relocate their jobs and or their homes. They're working with new people, new bosses, new physicians, and layoffs were hanging over our heads pretty much from the beginning. Now, everyone at UTMB got paid for 4 months, whether you worked or not. Some folks simply did not have a job to go back to, and in other cases, because we were not able to have inpatient beds, no trauma center, no critical care for a while, no OR, there had to be layoffs to accommodate severe shortage of funds to cover the salaries of folks who would no longer be working. I don't remember off the top of my head. It was over 3,000 people that got laid off after a couple of months. So folks didn't know if they had a job or not initially after the hurricane, and you're dealing with all kinds of homes are gone or severely damaged, unlivable. Insurance, FEMA, contractors, repairman, all of this is going on, and you're trying your best to do your job. The impact of point of care, of course, is we were all trying to be vigilant that nobody made any kind of error in point of care or outside of point of care. We're looking for ways to maximize the workflow and work with fewer people. The timeliness of reporting, we did not want that to be a problem for the providers, and yet everyone was pretty much maxed out on how much they could get done in the circumstances that we had. Observed drawbacks of using point-of-care testing. Some cases when it did not work optimally. The access to the clinic areas that were damaged on campus, there was no access. The doors had to be locked. There was a concern, of course, for looting, and there was a concern that epidemiology, infection control did not know what the environment would be like to go back in and to pull things out. So professionals, a professional cleanup agency was used to come in, pack up what was there, cart it out, and then the owners had to claim these things, had to be surface clean, and then transported to storage before it could be put back into circulation. All of this, of course, took time. So even if we had available devices for point-of-care testing, we didn't have access to it. And that's something you have to consider in a backup plan. Do you have to have items outside of the area where they're normally being used as your backup plan? Because if they're in the area where you're actually working, it's locked up. You can't get to it anyway. Flooding, ceiling leaks, compromised point-of-care devices, because the nature of point-of-care is that they're small enough, they're sitting on the counter, or they're attached to the wall. The base units got flooded out in some cases. The connectivity was a problem because of where the electrical outlets are, the digiboxes and that kind of thing. In some cases succumb to the water. One of the other drawbacks of point-of-care testing is that it takes multidisciplinary departments to achieve connectivity. For example, there was unavailable resources as far as IS and lab employees to reestablish connectivity, to reestablish where the glucose meters were supposed to be moved to when we were trying to get back to campus with clinics. We had to reorganize where the clinics were going and what the needs were, and that meant moving or IP addresses moving. There was a time delay in trying to get those services which were needed. One of the benefits of point-of-care testing, as I said on the other slide, was sharing of resources, of reagents and supplies, because we had some redundancy off campus. But yet there is a drawback when you're talking about point-of-care testing being in off-sites because of the geographical nature of how spread out the system may be. As I mentioned before, we have a regional maternal child health program clinic 180 miles away. So you don't want to rely on sharing supplies throughout the system. The next slide brings the drawback of CLIA certificates. It's hard to describe, but on a daily basis, the clinic services were shuffled. I honestly didn't know from day to day who might be at every given clinic, because you had to be very flexible as to where the need was. And as a new site would open, then we could redistribute who was working at what site. I had to try to keep track of what appeared. A couple of microscopes appeared. I have to assume that when the physician, and it's usually a dermatologist for me, when the physician evacuated, I think the microscope went in the car and then reappeared because I would see a microscope in a site that I didn't think had a ppm but had a CLIA waived, and then I'd have to scramble about that. Operators, I didn't know them by sight because half of the operators I was now seeing had come from campus, and I had not worked with most of those people. Some of the people I actually remembered from when I worked on campus, and so that actually was the plus in all of this. I got reacquainted with some really, really neat nurses, but part of the problem was I didn't recognize them. I had not done their competency. I had no idea what they were validated to perform. Part of the problem was they didn't either, because the paperwork could not be established because it had been in clinics that were flooded. And if the managers did not have a redundancy, did not have a backup plan, that it was on the information was on a server, for example, then I couldn't get that information. Because of our campus lab being closed, I didn't have access to the campus coordinator looking up the databases, for example, on the online tests. Otherwise, I could have gotten the dates of the online test, and we could have moved forward that way. Applicability to other disasters or emergency. I stuck in swine flu because that came down the pike for us in Texas the very end of April and the beginning of May. Because of the close proximity, of course, to Mexico, it was an emergency when it broke into the news in our area, and our epidemiology and infection control group immediately was on it and took it very seriously. I don't have the whole protocol here because it's not my protocol, but the bottom line is what happened as folks would try to come into the healthcare setting either through the entry of L&D or the entry of, we have a Texas Department of Corrections, and they intake through the clinic area, and our off-site clinics in particular, and our campus clinics were open then for folks showing up with symptoms, and we wouldn't know, well, what did they have. So our front office people were garbed and doing verbal questioning of the patients and or visitors who were showing up at the doors. And depending on the screen, if it was considered a positive verbal screen, the folks were given protective PPE to wear and taken immediately back to rooms, not put into waiting room situations. And one of the first things that happened was a rapid flu test. So I put this slide up because I never would have thought of using a rapid flu test as a disaster/emergency response, but it was, because it was not a point of care decision to use rapid flu testing in that manner. It was a decision by epidemiology, infection control, and they mandated that this would be done. So then point of care had to scramble and respond to that demand. Other applicability to disaster settings would really be any other weather-related incident that would be of long duration, particularly if you're going to lose electricity over a period of time, water supply, sewer service. Occasionally in off-sites we have outages because transformers are hit, power lines. That's usually very short-lived, but I imagine in a situation where you had other flooding or you had tornadoes, you could have power interruption for a period of time, and that would cause disruption of providing your patient laboratory services if you were not using point-of-care testing. We have another scenario on campus that not too many people would have this combination, but we also have to be concerned about homeland security or non-natural disaster emergencies. And that's because we have a biosafety level 4 laboratory, we have Galveston National Laboratory, and we have the Center for Biodefense and Emerging Infectious Diseases. If you look at the bottom right picture, the building furthest away that looks like tubes coming out of the roof, that is the GNL. Lastly, to get into some recommendations and suggestions, one of the quotes I like from Dr. Kost's talk is, "Practice makes preparedness. Everyday use of point-of-care assures proper training, quality, and competency in times of need." I would absolutely second that. It's very difficult for me to say to someone, plan for the unthinkable, but yet you must, because the one thing that I heard constantly after UTNB suffered so much damage is, well, we didn't have the generators go out before. This time we did. Well, we never flooded on the first floors. Well, this time we did. It had a severe impact. So you've really got to think of, what do we think can't happen, and try to plan for it. I highly suggest, everyone always says you have to have it in writing, and that really is key, because as happened this time around, you honestly are not sure who's going to be able to come back in an evacuation scenario. Key employees, not everyone is going to be sheltering in place on campus. Key employees are going to leave, and you have to find a way to get a hold of them. You have to know what the plan is when you're transferring services from one department to another, from campus to off campus. That kind of thing has to be taken into consideration. You want to know what the system and the facility acceleration plan, the contingency plan is. How are patients going to be relocated if you're going to continue to see patients after the disaster happens at your facility, at your university? Do try to consider, if you're working at a facility that uses connected devices, try to consider, if you are going to keep using point-of-care testing, do you have a backup plan if you do not initially have connectivity up and running? Recommendations also include redundancy or backup plan for competency. If folks cannot remember, or you don't want to use the honor system in when their last competency was, databases have to be on servers that can be retrieved, access retrieved after disasters, not relying on paper and filing systems. It would be really helpful also if you had an electronic medical record in place that all your point-of-care operators are documenting point-of-care testing in the same manner. That was a teeny bit of a problem for me because not everyone on campus was using Epic at the time of the hurricane. And when the folks came out and they were using Epic off-site because all of the off-sites were using Epic, it was a problem because they didn't know how to document their work. It was not consistent. And then we had to put some training in place. And post-disaster is not a good time to be doing any kind of training that's not essential for the operations of your patient care recovery. Lab support and leadership, it's imperative that even if the laboratory itself is not able to be running or to be operating because of infrastructure problems at the site, it's really ideal to have the support coming from the laboratory as nurses and physicians are moving from campus to off-site areas. The next slide. It seems obvious that everyone would have a contact list for the folks that they use on a daily, weekly basis as far as vendor, industry reps, but that was not always the case this time around. So have those contact lists, have the cell phone list. Keep in mind, if you personally have been lucky enough to never go through an evacuation or any kind of a disaster, most often one cannot rely on cell phones. Texting works, but cell phones, there's so many people that try to use the phone system that it's jammed initially after a disaster. So have a backup plan with how you're going to communicate with folks. Strict pre-disaster stance on discard of expired products. This sounds maybe a little silly to folks who think, what has that got to do with anything? Well, let me tell you, we spent a lot of money this time around on rescuing supplies out of buildings that I've already described get locked up. A professional crew comes in to pack, to transport out, to surface clean, to store, to transport to where it can be used, and then I've gone in to try to unpack and distribute so that we can use these supplies, and I'm tossing out things that have expiration dates of 2002, 2003, and I'm getting upset because of the money that was spent and the time that was spent rescuing things that we can't use anyway. Please try to keep up with that as you go along and make folks understand that it just can't be tolerated to stockpile things that cannot be used anyway. Other recommendations on the next slide. Available clinical equipment services. This is something that most people overlook also, but I knew from other experiences that this was a telephone number I absolutely was going to have on day one, because you will try to go back and use backup equipment that you have stashed away. You will try to borrow. You will try to get things from other community hospitals near you. You will ask for loaners from industry reps, for example. And when those items come, you're going to need clinical equipment service people to tag them, to check them out and make sure that they are inventoried so you know if they get moved around to whom they belong, to whom they have to be given back to. Have a contingency plan for using a reference lab. I've touched on this a little bit, but it's very helpful if pre-disaster you know who you're going to call if you are not able to use your own laboratory, and you need to know if they can set up shop the next day. You need to have a current list of your NPIs for physicians that you're going to be adding to existing accounts. And you need to handle drop-in patients that come in for phlebotomy and lab. If you're not going to be handling them on site as a point of care test, then you need to be able to get that blood drawn, sent out as a reference lab. T-shirts say it. This is just 3 that I was able to snag pictures of that we had on campus. The middle one we deliver, I guess is my favorite because it looks like a sonogram, but it's inside the Hurricane. Lastly, I would like to conclude my talk and thank you for listening. I'd like to conclude it with, on a personal note, thanking a few folks who I believe kept me sane during the whole 6 months post-hurricane for me. And I'd like to thank Deanna Bogner in Texas and Marina Trout in Colorado, Pat Kraft and Pat White, both coordinators in Ohio. I also would like to thank the glucose industry rep, John Hamilton, and Rashana Green, also an industry rep who came in with just a really great attitude and helpfulness when I had to ask for help to get meters. And I just can't thank them enough for the support that they gave me. And thank you again for UC Davis for inviting me to participate in their series.